Plenty of people are there, sir. Plenty are there.
And it's okay. So can I just said that because morning I was listening in between, and in between myself and Dr. Mitra section, I had to be in another Trichy society. This thing. Okay. So we had,
thank you, sir. Thank you for accommodating me.
Okay. Okay. This is my talk is based on the recent guidelines, basically mainly on the FIGO guideline of 2018. Now the 2021 FIGO guideline is already completed and it will be published in this year, in November this year. The next one I have looked at is the National Cooperative, the National Comprehensive Cancer Network guideline, which is NCCN of 2019, and also the RCOG Green Top guideline of 2020. So there are many other publications, and being a rare disease, not a very common disease, the controlled randomized controlled trials and based on which the guideline is not very much there, but there are observations and also from the experience that there are certain studies also available. So based on this thing, these three major guidelines I looked into, and based on this, I have drawn conclusions, and whatever I am going to talk is on based on that. Now, the management of the adaptive mole. I'm not going to diagnose it because nowadays scanning is being done by 6 or 7 weeks, and you are going to miss it. 100% you will miss it because the classical findings of ultrasound is seen only after 10 weeks, maybe earlier by 9 weeks. The classical findings are very easily made out by 12, 14 weeks, but nowadays nobody is waiting up to that. So you miss a lot of, or some cases of vesicula mole in the early part of the thing. So these cases are going to come with a GTN later on, and you have got problem in it. Anyway, in a classical case, suction evacuation under anesthesia is the method of choice, regardless of the size of uterus. There is one statement: ultrasound guidance, if possible, will help to minimize the chance of perforation and also help to complete removal of the moles. If you have it in your theater or anywhere. In all cases of RS negative mothers, you should give anti-D prophylaxis, irrespective whether it was a complete mole or partial mole. Complete mole, people now say that there's no need because there is not much of RBCs formed in it. But by the time you get the result of complete mole or partial mole, you are losing that golden time limit of 72 hours. So you can give to all patients before getting the report. Now, the next question is to make it easy for the evacuation. Now, whatever problem nowadays we see is the incomplete evacuation of the mole and persistent bleeding and rise in HCG, and then thinking of GTN and starting chemotherapy. This is very unfortunate. That is just because of the incomplete evacuation of the moles. To aid the complete evacuation, probably there is a place for cervical ripening, which we used the osmotic dilators at that time, the laminated 10, people who are critical whether it will produce infection. Of thousands of cases we have done, there was not a single episode of infection. But you can use the prostaglandin E1 just 2 hours or 3 hours prior to your planned evacuation. It will make the cervix soft and easy for dilatation so that you make a complete evacuation is possible. We are not using the medical abortion in molar pregnancy because of the fear of embolization and dissemination of the trophoblastic element. That is why it's not recommended. But in case of partial mole, where the fetus is there, not easy for removal by suction, there is a place of induction of abortion with prostaglandin also. Then the question of oxytocin during the time of evacuation. The guidelines are having difference, especially RCOG says only at the completion of the procedure. Our international association as well as the FIGO says from the beginning of the thing. Whatever it is to prevent the excess bleeding and the chance of preference. So when the uterus is more than 16 weeks, it is always prudent to start the oxytocin from the very beginning. In such cases, the moment you put the cannula in, there will be a gush of blood and bleeding. To control that, it is better to have the oxytocin from the very beginning. But you can do if there is a no bleeding, you can probably do it at the end of the procedure to make the uterus contractant. Then it is also necessary to have a gentle curettage at the end of the evacuation so that you remove the molar tissue completely. Again, incomplete abort evacuation is the process problem for persistent irregular bleeding and rise in HCG, unnecessarily thinking of GTN and starting chemotherapy. So make sure at the first sitting itself, it is completely evacuated. Hysterectomy, not hysterotomy. In our we do hysterotomy at all. That's why any size it is evacuation. Hysterectomy with the mole in situ in elderly primiparas who doesn't require further childbearing function is advisable. And this will reduce the risk of invasive mole and bleeding. But it will also have the risk of choriocarcinoma in 2 to 3% of cases. So all these patients will require HCG follow-up and clinical follow-up after whether it is section or hysterectomy with the mole in situ. Now, the question of prophylactic chemotherapy, it is controversial, but in a special situation where the patient is having a high risk for developing choriocarcinoma or GTN following a molar pregnancy, and in a situation where the patient is not possible for the patient to have regular follow-up because of the social reason, then in high-risk patient, there is a place. But there is no benefit by giving prophylactic chemotherapy in low-risk cases of vesicular mole. The high-risk cases are age of the woman over 35 years, size of the uterus more than 4 weeks of the gestational age, a pre-evacuation HCG of more than 100,000, and presence of large luteal system. These patients may benefit, and such elderly patients are having the risk of developing GTN. At least 30 to 40% of them may develop. So you can reduce it to 3 to 8% by giving prophylaxis. So there is a definite place for such situation. If they develop, the problem is that it will be more resistant cases. But if you are having regular follow-up, 100% of such cases can be identified and a proper chemotherapy and cure can be achieved. So that's why we haven't given, it is not our practice to give prophylactic chemotherapy, but there is a place. Follow-up after evacuation is immediately after evacuation. It is better to keep the patient in the hospital for overnight because she may develop sometimes bleeding. For some cases, it is seen that they may develop dyspnea, maybe during the evacuation. Massive embolization of the trophoblastic elements itself can occur, and that is very dangerous. So keep the patient for overnight in the hospital. Check the HCG next day, which may be the better basal value of an HCG. You have to call her back after 1 week to do a ultrasound examination to make sure the uterus is empty. You do a repeat curettage if there is incomplete evacuation. So at least within 1 week, you make sure the uterus is empty and there is nothing remaining inside. So subsequent development of the rise in HCG is not to incomplete evacuation. So make sure that there is nothing remaining by ultrasound scan the next week and then doing a curettage next week. HCG and clinical follow-up has to be followed. HCG follow-up is once in a week, but in a situation where we are not able to do it every week, it is okay to do the HCG once in 2 weeks even. It is sufficient. Initially, we were doing like that. We never missed any case of GTN. So once in 2 weeks, and once it has become negative, do 2 more or 3 more tests to see that it is remaining negative. Once it is remaining negative, then it is sufficient to have monthly checkup with the urine or serum HCG. Even urine HCG is okay because if it is negative, we are having very sensitive test kits now. So if it is negative, it is negative. And it is necessary only for 6 more months of follow-up, not years together, making the patient worried and other things. In partial mole, once it has become negative, just 1 more test after 1 month. If it is negative, she is free of the follow-up period. Contraception during the follow-up is necessary. It is safe to give combined oral contraceptive pills. It was thought that estrogen may stimulate, but now we know that it is safe. The question of a patient who had chemotherapy for GTN, in subsequent pregnancy, it is prudent to check the urine or PET HCG 6 and 10 weeks after subsequent pregnancy. Only to those who had GTN diagnosed in the previous molar pregnancy. Now, it is very important to counsel the patient very carefully, because I have seen death of young girls due to secondaries and all because lack of follow-up. And you see the young girls, this is our own patients who had come for the follow-up clinic, and this photograph was taken, I think, in 1990 or 91. And all of them are counseled and they are all convinced the need for it. Probably you may have to counsel properly that this is a condition which may lead on to something like a cancer, which if we do the regular follow-up can be detected and can achieve 100% cure. That is how you have to say, not to frighten, but at the same time, very carefully telling that it is necessary to have the clear follow-up. Now, diagnosis of GTN following hereditary hormone is usually easy, and we will not miss it if you have the regular follow-up program of at least once in 2 weeks HCG and clinical exam. The clinical examination, you must check for subinvolution of the uterus, persistence or enlargement of the thecal lutein cells, development of the suburethral nodule. These are all signs of GTN other than the HCG. So both clinical and HCG follow-up is there. How do you diagnose GTN following hereditary hormone? A rise in HCG for 3 values over 2 weeks time. A rise in HCG is increase of 10% of the value from the previous week. That is rise in HCG. A plateau means the value doesn't fall below 10% of the previous value. That is a plateauing. So with these things, you can make a diagnosis at the earliest possible. For single agent chemotherapy is going to be 100% curative. Persistence of the HCG after 6 months of evacuation is an indication for chemotherapy. If you get any tissue diagnosis of choriocarcinoma, that is GTN, there's no doubt. And in a special situation, when the HCG is more than 20,000 international units per liter after 4 weeks of evacuation, though is not GTN diagnostic, but these patients are at high risk of developing invasive mole, perforation, and internal hemorrhage. So this is an indication for giving treatment in such cases. The only important thing is HCG assay is only for pregnancy evaluation, not for malignancy. So we should see that in cases of GTN, all the abnormal forms of HCG are coming. The normal HCG with the free beta HCG, HCG-H, NICT-HCG, so all sorts of abnormal forms are coming. And the assay system should pick up all these abnormal forms. And it is seen that the system, which is Siemens Immulite, is the system which will pick all these forms of abnormal form. The ordinary pregnancy test may not be picking up all the forms. That is the importance. Now, choice of chemotherapy, again, every guideline is approving the FIGO risk score and staging system. The FIGO risk score is a modification of the WHO score, which is the modification of the RACSHO score. Now, we modified the FIGO score, WHO score by making it to low risk and high risk. In WHO score, there was intermediate score also. And in FIGO score, the maximum score is given for metastasis to brain and liver. So the stage 1 and 2 with the risk score of 7 is grouped as low risk, and we can think of single agent chemotherapy there. And cases with the stage 4 disease or risk score of more than 7 and above is grouped as high risk, and they have to be given multi-agent, usually IMACO. These are all by all the guideline, it is the same. Now, metastatic work. Having diagnosed GTN, you are not supposed to treat with a single agent or multi-agent. You have to really stage and risk scoring has to be done by metastatic work, whether it is high risk or low risk case. So metastatic work, post-molar molar pregnancy, molar GTN, a pelvic ultrasound. Again, when you have diagnosis, a chest X-ray is sufficient to rule out metastasis to the lungs. If chest X-ray or CT scan, if you are worried about it, is negative, no more metastatic work is necessary. And if the lungs are not involved, other systemic involvement is not seen. So that is, you stop there if the lung metastasis is not seen on chest X-ray or CT scan. But if it is there, then you have to go in for CT brain, MRI brain, CT chest, everything, because the metastatic workup has to be done if there is involvement of the lungs. Now, in cases following normal abortion, relapse or relapse of cases or following delivery, you have to have the complete workup, that is pelvic ultrasonography with the Doppler, CT chest, MRI brain, MRI liver and everything. So you have to have the complete workup. And depending upon that, you score the disease as per the FIGO scoring, that you consider age, antecedent pregnancy, interval and other thing. You should have the chart with you, so that if the score is 6 and below, it is a low risk. If it is 7 and above, it is high risk. Now, this is a wonderful beginning of the chemotherapy. Even the medical oncology has started after this success of Lee and Hertz reporting the first cure of choriocarcinoma in 1956. The event was described by the professor of pathology Arthur T. Hertig as God's first answer and man's first cure. So that was the importance given to that success. Otherwise, it was 40% death or hysterectomy as only treatment. So it has revolutionized, this finding has revolutionized the management of GTN, and we get near 100% cure in this condition. Now, choice of single agent, there was a question whether it is actinomycin, whether it is methotrexate. So one of the Cochrane review in 2009 and 2016 has put that methotrexate is inferior to actinomycin D. But unfortunately, this trial was a pulsed actinomycin D with weekly methotrexate. We don't believe in weekly methotrexate, even though that is one of the regime. It is not with the 5-day multiple doses or 8-day methotrexate folic acid. And recently, there was a trial which was stopped because of lack of number of cases, has proved that methotrexate is superior to actinomycin D. So we were from the very beginning presenting these findings in the international forum, and I was arguing that our experience is always with methotrexate folic acid, which some of them didn't agree, but finally I am happy to see that now their own randomized trial has shown that methotrexate is superior to actinomycin D. And actinomycin D is more toxic than methotrexate. So methotrexate, we all know that methotrexate alternating with folic acid 8-day regime. That 8-day regime is one of the minus point, but they can come daily and take the injection, see that there is no toxicity. Before starting the course, you should have the complete blood count, LFT and RFT, because the drug is detoxified in the liver and is excreted partially by the kidney. So if the kidney and liver is at fault, then she will develop toxicity and she should not be anemic. The hemoglobin should be at least 10 grams. If there is fever and infection, that will also precipitate the toxicity, which may kill the patient, not the disease. So you have to be extremely careful to see that the hemoglobin is normal, the liver and kidney function are normal to start the game. And before starting every course, you have to repeat all these things. And also the HCG to see the effect of the treatment that you are giving. So once it has become negative, then you may have to give at least 2 more courses. If the response is poor, then you may have to think of alternate therapy. That is the way you have to go. That is what is recommended by all the guidelines. The guideline recommends multi-day methotrexate regime as first-line therapy in low-risk DGTN. Now everybody has come back to that. That multi-day therapy, that is 5-day methotrexate or 8-day methotrexate folic acid, than the actinomycin to start with, actinomycin. If there is a slow response to methotrexate, then need not go for the multi-agent therapy again. You can switch out to actinomycin D. And it is found that those cases which is not responding to methotrexate, actinomycin can achieve further 70-80% cure of the remaining cases. So that you are risking the patient with the toxicity of multi-agent therapy is minimized. Finally, maybe 2 or 3% may finally require the multi-agent therapy. So one single agent, if it is not responding, go for the next single agent, and thereby you reduce the risk of toxicity and then get complete cure. Only 3 or 4% or 5% may require multi-agent therapy. And in cases with the risk score of 4 and below, 100% sure, 100% result of cure, and which is 5 and 6 may get even 90-95% and rest of the thing by multi-agent. So that is the beauty of treating, diagnosing and treating it. Lowest region, we said that it is again 5 and 6 may not respond to single agent very effectively. So that's a special group now. We haven't put it as intermediate. Still, it is in the lower group, but you have to have a low threshold for group score 5 and 6. You start with one single agent. If not responding, and if the SCG is less than 1000, you may think of actinomycin D. But if the SCG remaining above 1000, it is said that you may directly go for multi-agent. So in any case, up to 6, you may try the single agent. In 5 and 6, you have a low threshold for starting multi-agent therapy. Seeing the response, you will switch over to multi-agent, especially if the diagnosis is choriocarcinoma is also there. So we can think of single agent in majority of the cases of low risk. Some of them may not respond, which will respond to alternate single agent. If not, they are not responding, you will go for multi-agent and thereby achieve 100% cure in all these cases of low risk cases. High risk case, always. So don't just start the chemotherapy after having seen the CG rise. You have to stage it. You have to have the risk scoring and decide on the therapy. If it is high risk case of 7 and above, always go for the multi-drug therapy. IMACO is the choice. We have got EP regime and so many other regimes. So multi-agent therapy is only for the high risk core. Now there is one more group which is being grouped in FIGO guideline as well as in NCCN guideline is the ultra high risk, where the score is 13 and above. The problem with such cases is that it may produce tumorolysis and patient may collapse and die. So there is what is known as induction therapy by low dose 1 or 2 drugs and 2-3 courses, and then start the multi-agent therapy. That is the ultra high risk. Follow-up after chemotherapy, risk of relapse is almost 3% recurrence of tumor is there. So avoid pregnancy for at least 1 year following the chemotherapy, SCG weekly and then monthly and then probably lifelong, once in every 6 months is the follow-up. Elderly patients should be advised that if they want child, they have to have this thing. Okay, this is our result. We had 92% cure with methotrexate alone, and we had the combination of methotrexate actinomycin D. Also, we had very few cases, only 6% of them, I think, 13 cases only out of 356 required multi-agent therapy. So that is the benefit of early diagnosis, and there should be a center where these follow-up cases are done. Thank you very much. This is from where the data has come. That is our Calicut Medical College. I could see four of my students there sharing my session. Thank you very much. And they are all bigger than me. They are greater people and achieved very many things in life. Thank you very much, my dear students, who have become much, much bigger, greater people than me. Thank you very much.
No,
Thank
sir.
you, Dr. Mitra.
Sir, you're very wrong.